So, to treat this incredibly debilitating disease, doctors sometimes have to plunge a woman's body into a sudden artificial menopause?
Yeah, exactly. It's a really profound medical paradox, honestly.
Right, because they effectively have to shut off the main water valve to the house just to stop a severe leak upstairs. But in doing so, they create this absolute multi-system desert everywhere else.
It really sits right at the intersection of, pharmacology, tissue architecture, and just the sheer physical resilience of the human body under extreme hormonal withdrawal.
Which is exactly what we're going to get into today. So welcome to our deep dive. We are so glad you're joining us.
Absolutely.
Our mission today is to understand exactly how and why a specific treatment for endometriosis triggers such an aggressive cascade of side effects. We're talking about gonadotropin-releasing hormone agonists, or, GnRH agonists for short.
Right. And the goal of these drugs is to cure the severe chronic pain of endometriosis.
But the cost of that cure is often this absolute drought in the mucosal tissues of the pelvis. So to figure out the mechanics of this, we've pulled a massive stack of sources for you.
Yeah, we've got the European and UK clinical health guidelines, so ESHRE and Astigan. We've got comprehensive medical reviews, patient toolkits from national health systems, and some really dense, peer-reviewed molecular biology journals.
Specifically focusing on pelvic floor connective tissue and vaginal aging.
And what really stands out across all these sources, from the high-level patient care guidelines all the way down to the cellular level biology, is that they are all documenting the exact same structural and chemical transformation.
Right, we aren't just talking about a mild inconvenience here, or like a simple lack of surface moisture.
No, not at all. For the women going through this, the medically induced side effects can sometimes feel as disruptive as the underlying condition itself.
Wow, okay. So before we get into the actual mucosal drought, let's establish what this drug is doing to the body's master control panel, because endometriosis is fundamentally driven by estrogen, right?
Exactly. The rogue tissue implants, the ones growing outside the uterus, they basically feed on that hormone. So the medical strategy is essentially starvation.
Starving the tissue. So when conservative treatments fail, physicians bring in the heavy artillery, the GnRH agonists.
Right. These are drugs you might see under brand names like Prostap or Zoladex. And their sole function is to downregulate the hypothalamic pituitary gonadal axis.
The HPG axis.
Yeah.
Okay, walk us through how that chain of command normally operates, when it isn't being disrupted by drugs.
Yeah. So it functions as the body's central hormone command center. Under normal conditions, your hypothalamus releases a hormone called GnRH in rhythmic pulses.
Like a heartbeat?
Yeah, exactly, a steady rhythm. Those pulses travel a very short distance to your pituitary gland, signaling it to release two other hormones, luteinizing hormone, or LH, and follicle-stimulating hormones, FSH.
Got it.
And then those two hormones travel through the bloodstream down to the ovaries, which is the instruction to manufacture and release estrogen.
Okay, so when you introduce a GnRH agonist, it essentially hijacks that entire signaling pathway.
Right, it floods the system. The agonist binds to the receptors on the pituitary gland constantly. It completely overrides those natural rhythmic pulses we just talked about.
Constant binding. So
Yeah.
what does the pituitary do?
Initially, it's overstimulated. It kind of panics and releases a massive surge of LH and FSH, which actually causes a temporary spike in estrogen.
Wait, really? So symptoms get worse before they get better?
Unfortunately, yeah. For the patient, this can mean a severe flare-up of their endometriosis symptoms for a couple of weeks.
Oh, wow, that sounds awful.
It is. But very quickly, the pituitary receptors become totally exhausted. They downregulate, essentially shutting their doors, and the production of LH and FSH comes to a complete halt.
So the signal to the ovaries just stops.
Exactly. Without those chemical messengers reaching the ovaries simply stop making estrogen. The patient is instantly placed into a medically induced menopause.
Okay, so going back to our analogy, it's like discovering a severe leak in your upstairs bathroom. To prevent the ceiling from caving in, you run down to the basement and shut off the main water valve to the entire house.
Right.
You successfully stop the leak upstairs, meaning the endometriosis is starved of the estrogen it needs to grow, but now you can't even get a glass of water in the kitchen. The whole house just goes completely dry.
That's a great way to look at it. But to take that analogy even further, you haven't just stopped the water. You've fundamentally altered the environment of the entire structure.
What do you mean by that?
Well, once that main water valve of estrogen is shut off, the physical architecture of the kitchen, in this scenario, The vaginal tissues literally begins to
The
collapse.
tissue collapses. Okay, let's focus on that architectural collapse. Because reading through the cellular biology sources, the physical transformation of the tissue sounds really dramatic.
It is. So the vagina is constructed of three primary layers. You have the epithelium on the very surface, the lamina propria in the middle, and the muscularis at the base.
Okay, 3 layers.
And all three of these layers are absolutely packed with estrogen receptors, specifically ER alpha and ER beta.
So they're waiting for that estrogen signal.
Right. In a healthy premenopausal state, circulating estrogen constantly binds to these receptors. It acts as an ongoing biological instruction telling the cells to regenerate, build fresh collagen, and maintain a thick, elastic barrier.
But the GnRH agonist has completely wiped estrogen from the bloodstream, so those receptors are just sitting empty.
Exactly. And without that constant instruction to regenerate, the superficial epithelial cells simply stop dividing. We see the tissue rapidly thin out.
How thin are we talking?
Well, in a healthy state, that epithelial layer is about 8 to 10 cell layers thick. It acts as this robust protective cushion. But under the influence of a GnRH agonist, it drops down to just 3 to 4 cell layers.
Wow. So it loses more than half of its thickness, just like that.
Just like that. And the degradation goes even deeper. Beneath the surface, in the lamina propria, the fibroblasts, which are the cells responsible for building the structural scaffolding of the tissue, they become completely dormant.
We just go to sleep.
Yeah, they shift into a state where we call them fibrocytes. Concurrently, the expression of a crucial enzyme called LOX, or lysyl oxidase, absolutely plummets.
I actually saw LOX mentioned repeatedly in the molecular biology papers. Why is that specific enzyme so critical to the structural integrity of the pelvic floor?
So LOX is essentially the biological glue. It's the enzyme responsible for cross-linking collagen and elastin fibers. It's what gives tissue its mechanical stretch and its bounce.
Okay, so without it.
Without active LOX enzymes, the tissue loses its rugae. Those are those natural accordion-like folds that allow the vaginal canal to safely expand.
Right.
So the wall becomes pale, loses its elasticity, and becomes incredibly fragile.
This is where I have to ask, when a patient is handed a pamphlet and it lists vaginal dryness as a side effect, is that terminology kind of hiding the reality of what's happening?
It definitely minimizes it, yes.
Because if I read dryness, I just think, oh, I need a little moisturizer, no big deal. But the patient toolkits universally describe this state as causing severe physical pain, especially during intercourse or even just, daily movement.
Right.
Is it merely the friction of being dry, or is the tissue physically breaking apart?
It's breaking apart. The medical community formally called this genitourinary syndrome of menopause, or GSM. Because the tissue has lost its collagen scaffolding and thinned from 10 layers down to 3, it becomes highly friable.
Friable, meaning easily torn.
Yes. Friability means the tissue tears easily under almost any mechanical stress. Patients experience petechiae, which are tiny microbleeds from ruptured capillaries just under the surface, as well as actual lacerations or ulcerations with minimal friction.
Oh my goodness.
Yeah, so you're looking at a structural failure of the mucosal wall, not just a surface level lack of moisture.
Okay, so the walls are thinning, the structure is compromised, and the elasticity is gone. But a thin, fragile tissue can technically still be hydrated, right? Why is there a complete 100% absence of moisture?
That brings us to the fluid mechanics. The medical reviews transition from cellular architecture into the actual fluid mechanics of the pelvis, looking at where vaginal lubrication actually originates.
Right, because it's not like sweat.
Exactly, it's not sweat. There are no glands in the vaginal wall producing it. The moisture is largely a transudate, meaning it's driven by blood flow.
Wait, blood flow?
Yeah. Plasma filters through the walls of the blood vessels, crosses through the vaginal tissue layers, and pools on the surface to hydrate the mucosa.
And estrogen is the primary driver regulating that local blood flow.
Spot on. Estrogen dictates the activity of an enzyme called ENOS endothelial nitric oxide synthase.
Nitric oxide, which dilates blood vessels.
Right. ENOS generates nitric oxide, which is a powerful vasodilator. It keeps the blood vessels wide, flexible, and capable of delivering high volumes of plasma.
So when the GnRH agonist removes estrogen from the equation, ENOS activity plummets.
Exactly. The blood vessels rapidly constrict. The overall blood flow to the entire pelvic region drastically decreases.
So there's significantly less fluid being delivered to the area in the first place. But the biology studies in our stack revealed a second mechanism blocking the moisture, right?
They did, yeah.
It has to do with how the cells physically connect to one another. I mean, is a drop in blood flow really enough to cause a complete drought, or is something else physically trapping the fluid?
The cellular permeability changes are what truly lock the system down.
Yeah.
So in a healthy estrogen-rich epithelium, the cells are joined together by structures called tight junctions and lateral intercellular spaces.
Okay.
Now, despite the name tight junctions in a healthy state, these pathways actually have a low electrical resistance. They're somewhat permeable, allowing the blood plasma to easily slip between the cells and reach the vaginal lumen to provide that surface hydration.
But when the estrogen disappears, the internal scaffolding of those cells undergoes a massive transformation, specifically a protein called G-actin, right?
Yes, the G-actin polymerizes. It shifts from a dynamic, flexible state into a highly rigid, fixed cytoskeleton.
So it stiffens up.
Exactly. This physical stiffening of the cells massively increases the resistance within those tight junctions. The spaces between the cells essentially clamp shut.
It's as if border control suddenly erected a massive, impenetrable concrete wall right where there used to be, like a highly permeable chain link fence.
That's a perfect analogy.
The fluid is still circulating in the bloodstream, but it's entirely locked out of the tissue. The plasma is trapped behind the wall and physically cannot reach the mucosal surface.
Exactly. You have reduced blood flow from the lack of ENOS, combined with a physical lockdown of the cellular borders from the G-actin polymerization. The resulting environment on the surface of the tissue is an absolute desert.
Wow. Okay, so if the hydration is entirely locked behind this cellular wall, what happens to the organisms living on the surface that rely on that moisture to survive? I mean, you don't just affect the landscape, you completely disrupt the ecosystem.
You do. And the microbial shift is perhaps the most insidious, long-lasting consequence of this whole process.
Really?
Yeah. The vaginal surface is a complex, thriving microecosystem, and the bacteria that live there are completely dependent on the structural integrity of the tissue we just described.
Okay, let's walk through the normal biological cycle so you can see how perfectly engineered this ecosystem is before the medication disrupts it. Under normal estrogen levels, that thick 10-layer epithelium we talked about, it's constantly shedding its very top layers of cells.
Right. And those naturally shed superficial cells are heavily loaded with glycogen.
Which is basically sugar, right?
Basically, yeah.
Yeah.
And that glycogen serves a highly specific evolutionary purpose. It is the primary food source for lactobacilli.
Which are the good guys?
Exactly. The dominant protective bacteria that naturally colonize a healthy vaginal microbiome.
And as the lactobacilli consume the glycogen, they produce acid as a byproduct.
Lactic acid. This biological process keeps the vaginal pH safely below 5, maintaining a highly acidic environment,
So it's like a shield.
a chemical shield. It prevents pathogenic, harmful bacteria from gaining a foothold and multiplying.
But introduce the GnRH agonist, and the entire cycle collapses, the estrogen plummets, the epithelium thins out from 10 layers to just 3 or 4.
Which means there are suddenly no superficial cells left to shed.
So no shed cells means absolutely no glycogen available in the environment.
None.
The food supply is completely cut off.
The lactobacilli literally starve. And as their populations crash, the lactic acid production stops. Without that acid, the vaginal pH steadily rises above 5, shifting from an acidic shield into an alkaline environment.
Wait, so the physical dryness actually triggers a chemical change that invites severe infections. It isn't just, physical discomfort. It translates directly into an immune compromise.
Absolutely. In an alkaline environment, commensal bacteria, these are organisms that are normally just passing through or living harmlessly nearby. Like E. coli, migrating from the GI tract, they suddenly find a highly hospitable environment.
Oh, no.
Yeah, they thrive, they attach to the fragile tissue, and they multiply. This leads to profound tissue irritation, unusual discharge, and a drastically higher rate of recurrent urinary tract infections.
UTIs too.
Yeah, because the urethra and the bladder trigones share the same embryological origin. They're also packed with estrogen receptors, so they're undergoing this exact same thinning, fluid lockdown, and pH shift simultaneously.
It really is a cascading systemic failure. I mean, you shut off the estrogen to starve the endometriosis implants, and you end up collapsing the physical walls of the mucosa, paralyzing the fluid transport channels, and starving the protective bacteria.
It sounds like an unsolvable biological trap, doesn't it?
It really does. But understanding this exact multi-layered mechanism actually gives doctors a highly precise blueprint on how to mitigate the side effects without ruining the primary endometriosis treatment, right?
Exactly. Because we understand the cellular pathways, we can intervene at specific bottlenecks. The first line of defense is often systemic add-back hormone replacement therapy.
Okay, so this would involve prescribing something like a low-dose estrogen and progestin pill or a synthetic steroid compound like tibolone alongside the GnRH agonist injection.
Right. By completely crashing the body's estrogen, the GnRH agonist puts the patient at a severe risk for rapid bone density loss, osteoporosis, and intense vasomotor symptoms like hot flashes, especially if they stay on the drug for more than 6 months.
So systemic add-back therapy provides just enough circulating hormone to protect the bones and ease the systemic symptoms.
Yes, but the dosage is carefully calibrated. It stays low enough that it doesn't wake up or feed the endometriosis implants.
But the clinical guidelines, specifically NICE and ESHRE, point out that systemic add-back often isn't enough to rescue the local vaginal tissue. The drought there is just too severe.
Right.
So for the mucosal symptoms, the guidelines heavily recommend local vaginal estrogen. So these are like creams, tiny dissolving tablets, or rings inserted directly into the vagina.
Local estrogen is incredibly effective for this specific cascade of failures. Because it's applied directly to the affected tissue, it rapidly lowers the pH back to acidic levels, restores the thickness of the epithelial cell layers.
And it reactivates that endouse enzyme, right?
Exactly. It dilates the blood vessels and brings plasma flow back to the area.
Wait, I have to push back on the logic here. If the entire point of taking this intense menopause-inducing injection is to starve the body of estrogen to kill the endometriosis, doesn't handing the patient a tube of topical estrogen entirely defeat the purpose of the treatment?
It seems like a massive contradiction, doesn't it?
Yeah. Aren't you just feeding the disease you're trying to starve?
The key difference lies in systemic versus local absorption. The dosages of estrogen utilized in these vaginal creams and tablets are incredibly low. We're talking in micrograms. It's a fraction of what a systemic pill contains.
Oh, okay.
That microdose binds almost exclusively to the local estrogen receptors right there in the vaginal and urethral tissue. It gets used up locally. Very little, if any, escapes into the systemic bloodstream.
So it repairs the tissue in the immediate vicinity, but it doesn't circulate through the body to reach the endometriosis lesions on the ovaries or the bowel or the pelvic sidewall.
Exactly. The systemic absorption is so negligible that major medical guidelines state women utilizing vaginal estrogen don't even need to take an opposing progestin to protect their uterine lining from thickening.
Which is normally a strict requirement if you take systemic estrogen.
Right, an absolute requirement. So it really functions as a highly targeted rescue mission strictly for the mucosal tissue, totally bypassing the rest of the body.
Okay, that makes perfect sense. But for patients who absolutely cannot use any hormones, or perhaps those who prefer not to, what are the non-hormonal options to reverse this desert environment? Because the clinical toolkits emphasize that you can't just use like any generic lotion.
No, definitely not.
Yeah.
Non-hormonal vaginal moisturizers are heavily researched, and the science behind their formulation is highly precise.
How so?
A medical-grade vaginal moisturizer is engineered with polymers designed to attach to the mucin and the epithelial cells, physically holding water against the tissue wall for days at a time.
What?
But the critical factor you have to look for is osmolality.
Osmolality, referring to the concentration of dissolved particles within the fluid.
Right. The World Health Organization sets a strict recommendation that these products must have an osmolality of under 1,200 millismoles per kilogram.
What happens if it's over that?
Well, if a patient unknowingly uses a product with hyperosmolality, meaning the gel is too highly concentrated with solutes, it will actually trigger osmosis in reverse.
Oh, yikes.
Yeah, the concentrated gel will pull water out of the already dehydrated epithelial cells, damaging the fragile tissue even further.
So identifying a properly balanced isoosmolar moisturizer is critical to actually hydrating the tissue rather than desiccating it further.
Exactly.
And a patient would use those moisturizers regularly, like several times a week, simply to maintain baseline tissue hydration, whereas lubricants are utilized strictly at the time of sexual activity to temporarily prevent the friction and tearing we discussed earlier.
Right, they serve two totally different functions. Furthermore, there is one non-hormonal intervention that patients rarely associate with dryness, but it directly targets the hemodynamics we explored earlier.
Okay.
Pelvic floor physical therapy. Specifically, the exercise is often known as Kegels.
Kegels. You hear about Kegels constantly for incontinence or, postpartum recovery, but prescribing them for mucosal dryness. How does flexing a muscle create moisture?
Think back to the loss of estrogen shutting down the endouse enzyme.
Right, which constricted the blood vessels and stopped the plasma from filtering through.
Exactly. By actively forcefully contracting and relaxing the pubococcygeus and levator ani muscles, the patient is mechanically pumping blood back into the pelvic region.
Oh, wow. So you are physically overriding the vascular lockdown.
You are. That repetitive muscle contraction forces oxygenated blood and plasma back into the capillary beds, bringing vital hydration and nutrients to the mucosal walls, even when the biochemical signals are telling the vessels to constrict.
That is fascinating. Okay, let's zoom out and summarize the entirety of this deep dive. We started with a medical paradox attempting to cure the pain of endometriosis by intentionally inducing a temporary menopause. And what the sources reveal is that the acute dryness triggered by GnRH agonists is not just a surface level lack of sweat.
No, it is a profound, cascading, multi-system shutdown.
You shut off the main water valve in the basement, and the architecture of the house literally starts to crumble. The cell layers collapse from 10 down to 3. The internal border control erects concrete walls, those rigid, polymerized, tight junctions that trap fluid in the bloodstream, completely paralyzing the body's hydration channels. And finally, the lack of tissue turnover starves the good bacteria, rapidly turning an acidic protective environment into an alkaline breeding ground for pathogens.
It really serves as a stark reminder that in human biology, isolating a single variable is impossible. Every biological system is inextricably linked, structurally and chemically, to the next.
Absolutely. Now, before we wrap up, we always want to leave you with a final thought, something for you to explore on your own that builds on everything we've uncovered today.
And the medical literature raises a really vital question regarding the long-term implications of these treatments. We know that GnRH agonists are usually only prescribed for 6 to 12 months due to the severe bone density risks.
Right. It's designed to be a temporary medically induced drought.
Exactly. You stop the injections, the HPG axis wakes back up, the pituitary starts pulsing, the estrogen flows, and the normal cycle returns.
But consider the sheer scale of the disruption. If estrogen withdrawal causes such a violent, aggressive shift in the physical architecture of the vaginal mucosa and entirely wipes out the bacterial microbiome, how long does the tissue actually remember this trauma?
The concept of tissue memory, or, epigenetic or architectural scarring.
Right. Even after the drug is fully cleared from the system and the hormones return to baseline levels, could this 6 to 12-month drought permanently alter a woman's baseline microbial flora?
It's a huge question. Could the prolonged dormant state of those fibroblasts and the severe degradation of elastin permanently reduce the tissue's mechanical resilience for years to come?
Does the internal structure of the house ever truly go back to exactly the way it was before you shut off the main water valve?
It really is a fascinating and highly unsettling question to ponder. You can turn the water back on, but the pipes in the foundation might never be exactly the same.
Wow. Thank you for taking this deep dive with us today. Keep asking questions, keep connecting the dots, and we will catch you on the next one.